Haven't seen you guys in a while, but today I'm removing this big ugly mast cell tumor off the caudal thigh of a Labrador. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. So this was aspirated by the primary care vet, came back as suspicious of a low-grade mast cell tumor. And I'm always a little bit wary of making a histological determination of grade based on cytology because the association between the two is kind of loose, and so I'm always a bit careful about making that assessment. And so we warn the owners about the potential for this coming back a higher grade tumor than what we suspect based on the cytology. The alternative would have been to do a surgical biopsy prior to like an incisional biopsy prior to surgery. The owners were happy to just proceed with the surgery instead. What we're going to do is we can see that this thing is fairly loosely attached. I might get a texta, please, a Sharpie. All right, so what I'm going to do is I'm going to get, because it's presumed to be low or intermediate grade, I'm just going to get a couple of centimeter margin around the base. So I'm drawing that with a Sharpie. And I should be able to close this primarily. If I can't, I've got some skin here that I can do just a little advancement or rotational flap, so that shouldn't be a problem. All right, so I'll just retract this out of the way, and I'm going to make some points at the end of my ellipse, just so it's going to be easier to close primarily. Let me pull just the plastic sleeve off. Not a very exciting surgery for me to make my reappearance on YouTube. I know I haven't recorded a lot of videos in a long time. I was just in Abu Dhabi at the World Veterinary Association Congress. So that's where I've been. I want to be a bit careful with handling the tumor too much because I could potentially contaminate the wound, so I will lavage that before we close. Might be getting a little bit light, just to be aware. So as we know, the biggest prognostic indicator with mast cell tumors in dogs is the grade of the tumor. We've got two different grading scales. We've got the Peckneck grading scale, which is 1, 2, and 3, with grade 1s having about a 5% chance of metastasis, grade 2s having about a 15% chance, and then grade 3s having about an 85% chance. The new grading scale is called the Kupfel scale, and that is just low and high grade, with low grade tumors having about a 5% chance of secondary spread and high grade tumors having about a 90% chance of secondary spread. All right, so that's our margin there. I'm pretty happy with that. I'm just going to see if I can feel the popliteal lymph node. If it's really obvious, I'll go ahead and take that out, submit it for histopath. So the node should be right underneath here, but I can't feel it, so I'm not going to go digging, because if I do get a dirty margin, I could potentially contaminate all those tissues. Can we get some saline, please? Just do a little bit of lavage, and then we'll do some mepivacaine as a splash block. Now I'm just going to see if I can see any of the questions. No pressing questions that I can see. I'll go back when I'm finished and just review the questions to make sure I haven't missed any. Can I get some mepivacaine, please? So I'll just inject some mepivacaine into the skin surrounding. So the question was, were there any signs of metastasis? And the answer to that is no, there were not. Again, we're suspecting this is a grade or a low-grade tumor based on cytology. No evidence of lymph node enlargement. We have not done abdominal scans. If we were concerned about a higher grade tumor, we would have done abdominal scans before surgery. The owners are aware that it could possibly come back high grade, and so if that were to happen, we would then do abdominal ultrasound to look for evidence of secondary spread, and also recommend chemotherapy. I think we're both shaking. Okay. Just had to coordinate our shaking. All right, so we're just getting the mepivacaine here. And whenever we're doing any kind of surgery, we really should be thinking about how we could do a local block, because nothing is as effective for pain relief as a local block. It has the highest effect and the least likely systemic side effects. So that's part of our surgical checklist, is have we considered a local block? Again, in the majority of cases, we're going to try to do something locally. All right, can I get some 2-OPDS, please? Again, if I haven't answered your question yet, as soon as I'm finished with the surgery, I'll go over and read the questions out. So the question is, could mast cell tumors cause multiple cysts in a cat? I haven't seen it behave that way. Certainly if it was associated with that, you would think that if you did cytology on the fluid in the cyst that you'd have mast cells in there. I'm not aware of that being a syndrome. That being said, the incidence of mast cell tumors in cats is quite low. We don't see them very often. They do tend to be more benign than they are in dogs. And there is a syndrome of systemic mastocytosis in cats that will have a splenic mass, and then you remove the splenic mass and that completely resolves the entire systemic disease, which is interesting.
What's your chemo protocol if necessary?
So chemo, we've got 3 different protocols that you can use for mast cell disease. You can use Palladia, which I think is tisarenib. You can use CVP, which is cyclophosphamide, vinblastine, and prednisolone. And then you can use CCNU, which is lomustine. The CCNU and the Palladia are both oral medications, and then the vinblastine is intravenous. I'm not a medical oncologist, though, so I don't do chemotherapy myself. So Stelfonta is the so-called rainforest extract, where they identified a plant in Queensland in the rainforest, and basically it just causes really, really severe necrosis of the tumor. I have tried it on 2 patients and found both of them were very, very systemically ill. I don't think it offers any advantage over just a good mast cell tumor surgery, and so it's not something that I would ever use again on one of my patients. Until proven otherwise, I think that my surgeries are much more effective than the use of Stelfonta.
Do you combine different types of local anesthetics in the same syringe? Does this have any effect on masking effect on drugs?
So the only combination that I could see using would be like combining mepivacaine and lignocaine. Lignocaine is going to give you the quick onset, but it only lasts about 45 minutes, in contrast to mepivacaine or bupivacaine, which is going to take about 45 minutes to take effect, but then is going to have effect for 4 to 6 hours afterward. And so you certainly can get a combined effect from two different drugs, but since we have our patients under anesthesia, we just pretty much use the longer acting medication, which is either bupivacaine or mepivacaine. So good question, and that is whether I use prophylactic antihistamines when I do mast cell tumor surgery. I do not. I've taken out as many mast cell tumors as anybody has, and I have not seen an issue. When I was at Colorado State University on the surgical oncology service there, which is arguably one of the biggest and busiest surgical oncology services anywhere in the world, we did not use antihistamines prophylactically, and so I don't find it to be necessary. I have heard anecdotally that some people have seen mast cell degranulation, and as a result they do use it, but again, it's something that I personally don't use and don't see the necessity.
Do you suggest you have multiple cyst tumours and I do cytology and I found a mast cell of the erogenous spleen?
Sorry, can you repeat the
So
question?
you suggest if I do have multiple cyst tumours, I do a cytology and I found a mast cell of the erogenous spleen?
So I'm not saying that that's the case at all in cats. I'm just describing another syndrome, which is systemic mastocytosis, where if the spleen is removed, then that resolves the systemic mastocytosis, but I'm not saying definitively that those multiple cysts that you are seeing could be related to systemic disease. So you'd want to do cytology on those, find out if there are mast cells present, and you might consider consulting with a medical oncologist in that case, because that is out of my area of expertise. Can I get some more? I'll just get some 3-0, please. Thank you. They can start on my next one, please.
Okay. So do we need to keep margin in facial mast cell tumours with the costs of sacrificing an eye?
So the question is, do you need to take margins for a facial mast cell tumor if it requires you to sacrifice an eye? And the answer to that is, if you skimp on your margins, you are likely to have recurrence. So in order to avoid having recurrence, you either need to take a wider margin or take a narrow margin and then check your margins histologically and see if they're incomplete. And if they're incomplete, you're either going to have recurrence or potential for recurrence, or you can reoperate and get a wider margin and take the eye then, or you could follow up with radiation therapy. So there are, I guess, 3 different options here. One is to take a wide margin and include the eye. The other is to take a narrower margin, but check your surgical margins and see if they're close. And if they are, follow up with either a wider surgery or radiation therapy. There isn't any evidence, to my knowledge, that chemotherapy prevents local recurrence with mast cell disease. There is evidence with soft tissue sarcomas that metronomic chemotherapy is going to prevent local recurrence after an incomplete margin.
How about oral PRED? I've seen people starting PRED and mast cell tumours got smaller before surgery.
So, good question. Do I use oral prednisolone to downstage the tumors before I take them to surgery? And the answer to that is no. The concern is that if you give them pred, it just makes the mast cell tumors look smaller, and it might give you a false sense of security. But we don't know if it's actually shrinking the malignant cells or if it's just reducing the inflammatory reaction around the mast cell tumor. So when I take out a mast cell tumor, I want it to look as bad as it possibly can so that I'm going to get the widest margin. So no, I do not pre-treat with prednisolone, and in my opinion, I don't think it's a good idea.
Are you combining surgery and chemo?
So in this case, we suspect that it's a low-grade mast cell tumor. So at this point, we are not planning on doing any chemotherapy. However, if we send this off to the pathologist and it comes back that it's a high-grade mast cell tumor that has a high chance of metastasis, then we are going to discuss chemotherapy as an option. With mast cell tumors that are high-grade, with just surgery, with no chemotherapy, there's about a 20% chance that the dog will be alive at the end of a year, whereas if you do chemotherapy, there's about a 50% chance that it'll be alive at the end of a year to 18 months. So it significantly improves your survival time, but you aren't talking about a cure in most cases. So I just have to decide if I'm going to put in any skin sutures here as well. I think maybe I will do a little forward interlocking pattern. Can I please get some more 3.0 PDS? And I'm not using nylon because this is a black dog, and so it's a lot harder to see black suture material. Less of an issue with a forward interlocking, but it still can be a pain. So I'm being nice to the poor intern who has to do the suture removal. So Petra, post-operatively, we're not going to put a bandage on this. We're going to send the dog home on codeine and meloxicam. And in hospital, it can get methadone until morning, when we'll switch it to codeine. Beg your pardon?
0.1 meloxicam.
Yep. All right, so I'll just come over and make sure I've answered all of the questions. And we'll be inking these margins. So let's just see. So the signs of systemic signs we saw with Stolfani, these dogs were just deathly ill, like really, really sick after administration the following day, like inappetent, vomiting, diarrhea, that kind of thing. So the only way to differentiate skin tumors is on histopathology, or you can try cytology. Cytology will often pick up lipomas, mast cell tumors, and sometimes soft tissue sarcomas. Let's see. Anesthetic, we used a pre-med of methadone and acepromazine, induction with alfaxan, which is like propofol, and then maintenance with isoflurane. And then, did you have to do fentanyl boluses or anything during the procedure? No. So that's it. All right, so coming down, I'm just looking at other questions. So I think that I've answered everything. I may be live streaming a patella luxation in a little while. It just depends on what theater I go in and if I can get the camera in there. So thanks a lot for watching. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. And I will talk to you soon.